studying EKG rhythms over the week? Did we make it through all of these? Anxiously awaiting the answers? Alright, so remember there's a bunch of them on here that you didn't have to know, but we're still going to look through and we're going to talk about, see if you identified what's wrong with them, like did you figure out the rule that was broken? Because that's helpful. You don't have to know the names of those, but at least if you can recognize, hey, I see what's wrong there, you know, that's a helpful practice to do. So we're going to go through each one of these and we're just going to identify them. Once we identify, just so you have all the answers, then we're going to go through and we're going to talk about causes of the rhythms and then what we're going to do to treat. So we'll go through each one of those. So let's start at number 1. Let's see how you did. What'd you say? Sinus tachycardia. Very good. So the heart rate is 140. I'll take your word for it. It looks about 140. So 140. Is it regular? It's regular. Do you have a P wave for every QRS? Yes, you do. You can clearly see that's a P wave. You can clearly see that's a T wave. None of my rules are broken. The QRS fits in a big box. The QR interval fits in a big box. There's nothing else crazy going on. So absolutely, this is a sinus tachycardia. Very good. Let's see. Number 2. What is that? It is a heart block of some type. So if I look at it, what's my rate? 50. This is a heart rate of 50. Yes. So we got a heart rate of 50. Is it regular? No. What's wrong with it? The QRS is just not there sometimes. It's just not there. So do I have a P wave for every QRS? The ones that are there, correct. But I'm having P waves with no QRS. So when I have P waves with no QRS, that means you broke the PR interval rule because I don't have a QRS. So you broke my rule. So therefore it's a heart block. So this one is a heart block of some type. This one's pretty dangerous because it's not predictable. So I suddenly don't have QRSs. So this one's really dangerous. This is the reason why my grandmother had a pacemaker at 70-something years old. I'm pretty sure this is what my dad went into when he passed out at Jim Nix 2 weeks ago. Pretty sure this is what happened.
Did he at least get to eat?
At least?
Did he at least get to eat?
Y'all know, they brought him his food and they were on their way to bring it to him and out.
Were you there?
No, I get a call.
Golly.
I get a call. So who do I visit? I visited y'all at Wednesday for OB. Yeah, left there, got a call. Had to go to Grandview ER. Parents. You just need to know it's a heart block of some type. That's it. It is a type of heart block. Number 3. You don't have to know this one, but let's kind of talk about what's wrong. What's the only thing that's wrong with this one? All right, so we've got some irregularity. So I've got a heart rate of 60, so we're good. I've got a P wave for every QRS. None of my rules are broken. My PR interval looks good. My QRS looks good, but I have some irregularity here. So there's a couple of different rhythms this can be called, but that's what I wanted you guys to recognize with this rhythm is that it's got some irregularity to it. This happens with hormone changes. Like it's fine. It's just a little bit irregular. You don't have to know the name of that rhythm. All right, number 4. What is this? SVT, supraventricular tachycardia. That rate is really high. What is it? 190. It's super high. Is it regular? It is regular. Do I have a P wave for every QRS? It's too fast for me to tell. I don't know. So remember, we've got to clearly see a P wave and a T wave. If I don't see both of those where I clearly can identify this is a P wave, I have to say no, it's not there. So this is, I know that T wave look, when we think it's a T wave, we're not really sure. It looks real, pointed and peaked, but we can't do any of that stuff with this one because we don't know if it's P wave, if it's T wave, if it's what. So we're just gonna blanketly say this is SVT, so supraventricular tachycardia. I need to slow this down to see if I can further see what else is going on with it. Number 5. There is another sinus tachycardia. So this is your second sinus tachycardia. So heart rate is tachycardic, P wave for every QRS, regular, PR interval is good, QRS is good. Sinus tachycardia. All right, number 6, and there's a little extra little snippet there for us to talk about. That's number 6. Atrial flutter. So if I look at this, the first half of this rhythm is pretty quick. Looks like it's ticking along, like it's probably a tachycardic rate. And then what does this say right in the middle of it? Vagal stimulation. What is a vagal stimulation? How do we do that? How do we elicit that? Yeah, Valsalva, like bear down like you're going to have a bowel movement. And what does that do to your heart rate? Slows it down. So we've already kind of learned that in our previous semesters, right? That when you bear down, it kind of slows your heart rate down. So in this case, they had that person bear down, and their heart rate slowed down. So now I can clearly see what's going on. So this is a great example of a non-invasive intervention, a non-medication intervention to try and slow a heart rate down. So we'll come back to it when we start talking about treatments. It does. Remember we learned about Valsalva, slows your heart rate down. What's there, now what do we see? What are those waves called?
Flutter salt.
So sawtooth pattern, flutter waves, there's a lot of different words. But we clearly see the flutter pattern, or the sawtooth pattern. Do my QRSs look good? Yeah, QRSs look good. They fit within a big box. So my ventricles are doing just fine. So this is an atrial problem, atrial flutter. 7 you did not have to know, but what's wrong with that? All right, which way is my P wave supposed to go? It's supposed to be pointing up. So this is a problem because my P wave is up and down. So that's what I wanted you to see with this rhythm. That's called a junctional rhythm, just for those of you who like to know. So we can't say this is sinus, because the only way we can say it is sinus is if the P wave is going up. If it's going upside down, we don't get to use that word sinus.
You say junctional?
Because it came from the AV note, not the SA note, which is the junction. All right, number 8. This is probably the hardest one with the longest name of the rhythm, because it's actually 2. What'd y'all say it is? What'd y'all get? Anybody wanna- Did you get this is 2 rhythms? It's 2 rhythms in 1 EKG strip. So if you take this out, what do you have? Normal sinus rhythm. With, all right, SVT. What is our word that we learned that starts and stops on its own? Paroxysmal or paroxysmal. I don't know which way to say it, so I'll say it both. So this is normal sinus rhythm with a run of P, SVT. So we say that P, so we use our word paroxysmal in there. And paroxysmal means it starts and it stops on its own. This is 2 seconds. I can't intervene in 2 seconds, because the whole strip is 6 seconds. get that one and just didn't have confidence, or did we not get that one? Okay, I was like, nobody wants to say yes or no. That one's the hardest one on all of them, because it's two different rhythms. So that one's really hard. All right, what's number 9? Very good, so this is sinus rhythm with unifocal PVC. So why am I calling them unifocal? So each time I see a PVC, it looks the same, right? So the tracing's the same. One might be a little bit bigger than the other, but size doesn't matter. It's the actual shape that matters when I'm comparing if they're unifocal versus multifocal. So those are unifocal PVC. Now, literature, there's 2 different ways you can count the heart rate on this. Some literature says we do not count the heart rate with PVCs, and some literature says that we do. I am of the opinion that we do count it, because if you feel check somebody's pulse, when they have a PVC, you can kind of tell when one is weaker than the other when they have a PVC. So I personally like that you count it, but either way you choose, there's literature to support either one of those things. So we're gonna say sinus rhythm, because the rate's what? 1, 2, 3, 4, 5, 6, 7, 8, 80. Number 10. VTAC. Lethal or non-lethal? Lethal. Lethal. So we're gonna recognize this one. We're gonna treat it in medical emergencies, because it is lethal. We need to jump on it and treat it very quickly. All right, number 11. We kind of started to go over this last week, but we didn't quite make it. What's 11?
Pacemaker.
All right, so this one is a pacemaker. So we see that spike going straight up and down, and those are called pacemaker spikes. So we that was at the end of the day, y'all were dead, brain drained, so we just kind of said, we'll look into it more next week. So those spikes that go straight up and down, so this right here, it just goes whoop. That is a pacemaker spike. Okay, here's my next question. Is that pacemaker in the atria or in the ventricle?
Atria.
It's in the atria. Why do you know?
That's on the big one.
Because it's in front of the P wave. So it's in the atria. So it triggered the atria to beat, and then everything progressed as it should have from that point forward. So the SA node just needed a little kickstart from that pacemaker. We'll talk more about pacemakers when we get to treatments and stuff, but that is an atrial pacemaker.
Where would it spike for ventricle?
We're
Like it
gonna
spikes
see one in a
right
minute.
before the QRS?
Yeah, there's one on here too. Let's see, number 12. What is this one? Normal sinus rhythm. Don't try to make something that's not there. That's usually why people miss this one, because they're looking for something wrong. Trust that you see what you see, because that's a heart rate of 60. It does. Heart rate of 60. P wave for every QRS, it's regular. PR interval looks good. QRS looks good. Let's not try to make something that ain't there. Ew, 13. V-fib. So ventricular fibrillation. If you said torsades, I'm not going to hate on you, but we're going to see torsades in a minute. It's going to be much more organized, much more clear. This is gibberish. Lethal or non-lethal?
Lethal.
Lethal. So we're going to recognize V-fib. We're going to treat it in emergency. 14. I have no idea why 14 says 6-second strip. None of the others do, but what is it? Atrial flutter. So we see those flutter waves, that flutter pattern. The other one that we saw was pretty regular. This one is a little bit more irregular. That's just a flutter. Sometimes A flutter is regular, sometimes it's irregular. The big clue for A flutter is that sawtooth pattern, those flutter waves. Alright, 15, you don't have to know, but what's going on here? It's just PVCs. So this is a ventricular rhythm. It looks ugly. It's not fast enough to be called VTAC. Okay? For it to be called VTAC, the PVCs need to be together, and the name of the rhythm VTAC is ventricular tachycardia. So we can't call this one VTAC because it's not tachycardic. But it's nothing but PVCs. So not great. Not great at all. All right, 16. It is a heart block of some type. Heart blocks tend to be bradycardic, because this rate is 50, so it's a little on the slow side. My QRSs look good. I have a P wave for every QRS, but my PR interval is broken tremendously. And it's broken different ways each time. So this is a type of a heart block. I don't have to know which type it is, but this is a type of a heart block because you broke my PR interval rule. Because my PR interval should be consistent every single time. It should not change and be different. Every time I have a PR interval, it should be the same. So that's a heart block. All right, 17.
Spanish rhythm with multifocal.
Y'all get that? Sinus rhythm with multifocal PVC. Because this PVC looks completely different from this PVC. These are the same. So if that part wasn't here, if all I saw were these, I would say they're unifocal. But this guy right here, multifocal. Coming from at least 2 different spots in the ventricle. Normal sinus rhythm with multifocal PVCs. Which one am I more worried about? Somebody with unifocal PVCs or somebody with multifocal PVCs? Multifocal, because that means there's more spots in their heart that are irritated and trying to take over and throw everything off. More worried about multifocal than I am unifocal. 18. That one is AFib, and we clearly can identify this is AFib, not VFib, because why? I got good-looking QRSs up there. Now they're irregular as they can be, but when they're there, they look good. So this is an atrial problem. I get that all the time on this perfusion test. People mixing up AFib and VFib. Okay? AFib, people walk around in all the time. Y'all have probably taken care of patients who, at clinical, had an AFib rhythm. If you read that in their history, whether or not you saw it on their telemetry monitor or anything, or saw an EKG, but you probably read it in their history. People walk around with AFib all the time. Nobody walks around with VFib because those people are dead, trying to resuscitate them back to life. Okay. VFib is a dead person. AFib is somebody walking around right now. Make sure we don't mix those two up.
Do we have to recognize AFib with RVR?
No, I'm not gonna make y'all know that one. So AFib with RVR, because we're extra, we can't just say tachycardic AFib. So if AFib is a tachycardic rate, we give it a special name called AFib with rapid ventricular response. Why can't we just say tachycardic AFib? It's too easy. So that's all. If you see RVR, that's all it means, is that it's the heart rate's above 100. That's it. All right, 19.
VTech,
All right, so that is towards sides, the points. The French VTAC, which means it is a, what type of rhythm? Lethal rhythm, lethal rhythm. So this is tour sides. You see how much more organized it is over like a V-fib? It's very big, little, big, little. Whereas V-fib was more just like gibberish. Alright, what's going on with 20? That is a sinus rhythm, it barely made it in there, but we've got a pause in there. So that's sinus rhythm with a pause. That's a pretty big pause. I like that pause. Pretty significant. But it's there. Alright, 21, you don't have to know, but what's wrong with this rhythm? Ain't no P waves. And it's pretty slow. It's only a rate of 40. So it's pretty bradycardic. But there's no P wave there. So that's the rule that was broken. No P wave. 22. I shall return to 20. And then go to 22. Same rhythm. It's sinus rhythm with a pause. Because everything else looks normal, it's just, you got a space here where there's no beat, so you got a pause. 23. That is another version of V-fib. So the V-fib we saw before was a lot bigger, a lot more chaotic. This one's a lot more fine. It almost looks like asystole. Honestly, because it's getting there. So that's kind of how V-fib does. Like it's real coarse and big, then it gets real fine, and then it just goes completely flatline. So this person's a little bit worse off than the other one. 24, you don't have to know, but what's wrong there? Alright, so the QRS can be upside down, and that's fine. But what's missing? Missing a P wave. So the QRS being upside down is actually not a big deal. Because when we do a 12 lead EKG, we're looking all around the heart. So this may be a view where we're looking kind of upside down. But even when we're looking upside down, I still should see a P wave right side up. So it's not there. So yet again, another missing P wave. There's a lot of different ways we can have junctional rhythms. I don't teach that because there's nothing we can do about it. Literally, they'll say, yep, you got a junctional rhythm. Okay, move along. There's nothing to do. 25.
VTAC.
VTAC, very good. VTAC. We're gonna skip 26 because I ain't even worried about y'all at the time. What's wrong with that one? 27. It's kind of hard to see, but alright, it's a little bit bradycardic because I've got a rate of 50. It's regular. Do I got a P wave for every QRS? I do, but what rule got broken?
PR.
That PR interval is broken. So what rhythm is this? It is a heart block. So we're seeing that heart blocks look different because we've got 4 of them. We have 4 different heart blocks. First, second type 2, and 3. So there's a lot of heart blocks. Do it. PR interval. So it's gonna look different depending on which heart block you're in, but y'all ain't gotta know that. PR interval is broken, it's a heart block, period, done, heart block. Alright, 28 looks ugly, ugly. What's going on with 28? Alright, we're seeing some pacemaker spikes. Okay. Do you see 2 pacemaker spikes? This pacemaker is located where? The atria. Only one more spot. And the ventricle. So this is a dual pacemaker, an AV pacemaker. So it's a pacemaker in both the atria and the ventricle. So let's look at, because we saw the atrial pacemaker earlier. So it's right here, because I see a P wave. All right, and then we see this pacemaker spike right here. And what does this QRS look like?
PVC.
Like a PVC, right? So it looks like a PVC. That is expected. Every ventricular pacemaker, when you see that pacemaker spike in front of the QRS, it's triggering a PVC. That is normal, that is expected. It looks scary and ugly, right? But this is the normal AV dual pacemaker. So this is great. So dual pacemaker. A, we've got in front of the P wave, and B, it's in front of a QRS, but that QRS looks like a PVC. It's huge. 29. What's going on here that's not good? Alright, I got some wide QRSs over here, okay? What are we seeing that's dangerous?
Inverted T-wave.
That's part of the PVC. What are we seeing right there? You can't see that one, it's right on the line. Pacemaker spikes. So if I actually take this part off and I just look here, you see pacemaker spike, QRS, there's one right here, QRS, one right there, QRS. That's a normal looking ventricular pacemaker. Remember what we said, ugly pacemaker spike and then an ugly QRS. But what's, it's in the wrong spot. Okay, so a pacemaker spike, we said, there's only two spots it can be. Pacemaker spike has to be before a P wave, to be an atria, or it has to be before a QRS, or it's in the ventricle. It should never be anywhere else. So that is a malfunctioning pacemaker. Yes. So your pacemaker spike should only be in two places. Before the P wave, atrial, or before the QRS, ventricular. That's it. Nowhere else. Tell me, based on what we learned last week, this pacemaker spike is right smack dab on the T wave. What can happen? The heart's trying to relax, and a pacemaker spike came in and went, so what can happen? That R on T phenomenon that can trigger VTAC. So this is not the R on T phenomenon, but this can trigger it. R on T phenomenon is when we have a PVC or a pacemaker spike on a T wave and it shoots us into VTAC. This is an extremely dangerous rhythm because this person can go into VTAC with those pacemaker spikes. I have to brag on one of my students because we were at clinical one day and we had a lady who had coded. They ended up putting in a temporary pacemaker, which is just like in the cath lab, they go in at the same spot, like in the cath lab, and they put in just a temporary pacemaker. You may see that in the cath lab. Do you see that? They don't do it that often. It's usually emergencies like this lady had. But she was a post-code, and her heart just was not beating. They were doing transcutaneous pacing, and then they got her the temporary pacer. We had her like the next shift. This happened. So my student is watching the rhythm. The patient's starting to wake up. Her blood pressure's getting more stable. Like she's starting to kind of perk up a little bit. And then suddenly her heart starts working again. And my student noticed this started happening because the patient's heart started working like it was supposed to, but that temporary pacer was still shooting off regular intervals. And so we printed out the strip, we showed it to the nurse called the doc came in within a few minutes and was like, great catch, and he turned the pacemaker on. So she went back up, this is exactly what needed to happen, and my student caught it.
get to leave early that day, like, for that action she made.
I would never go back to the call, but I'm literally.
I'm done, give me the degree.
She got bragged on, she continues to get bragged on, even if I see her out in clinical, I'm like, I still talk about you. Alright, what is number 30? Ugly, right? It's a heart block. PR interval broken. Doesn't matter how ugly it looks. PR interval's broken, it's a heart block. What's the biggest issue here? What's my heart rate? 30 at best? Yeah, we're in trouble. What do those QRSs look like? Widen, they're PVC, they look, this is not pretty. This is the worst version of a heart block. Yes.
Okay, for every heart block, PR interval is broken.
Yep.
That's it.
That's it.
That's as deep as it goes.
Yep.
Okay,
That's as deep as I'm making y'all learn.
okay. Just making sure.
You wanna learn more, I'm happy to teach you.
I don't.
a great
I'm-
story on
I've
heart
got
blocks.
enough. I'm
Barely
kidding.
getting this.
I just wanna make sure.
I have a wonderful story to help you remember heart blocks, if you're just dying to know, but that's gonna be individual basis, not class basis. PR interval broken, heart block. Now this one, like I said, this one is, I'm more worried about this because the heart rate's only like 30 at best. So honestly, for this one, the bradycardic issue is what worries me more. That QRS is very wide, it broke that rule, like, ew, just ew, this is ugly. What's wrong with 31? You see a pacemaker spike? Oh. What's wrong with it? It's just hanging out by itself. It's a malfunctioning pacemaker. It's a malfunctioning pacemaker. Yeah, because malfunctioning pacemakers have several different labels depending on what they're doing wrong. So that's just getting more specific on what's the problem.
Do we need to know if it's like malfunctioning or?
There's different ways it can malfunction. I don't care that you know the specifics of what the problem is, just know that it's not working great. Like that's, for entry-level practice nurses, all you guys need to know is what a pacemaker is supposed to look like. And anything else that's malfunctioning, call somebody else to come fix it. So we just want to recognize when something's wrong so we can call in people to come address it. That's it. 32.
Great.
Sinus bradycardia. Sinus bradycardia, not that first degree heart block, sometimes are kind of hard to tell. You just gotta make sure that PR interval doesn't get broken. As long as my PR interval looks good, it's a sinus bradycardia. But it gets real close. There's a lot of times at clinical, I've gotta print out EKG strips and really look at it and make sure it's sinus brady and we haven't gone into a heart block. So sinus brady, PR interval is within a big box. 32, you didn't have to know, we ain't even going there. 34, we ain't even going there. 35.
You mean 33, Skip? Yeah.
Yeah, 33.
Okay.
Yeah, don't worry about that one. 34, we're not gonna worry about that one. 35, we're not gonna worry about that one. However, I will say, this is the worst case scenario of that heart block that we saw earlier. This is why my grandmother got sick. She did 10 seconds worth of this. Make her intense. Alright, how do we feel based on what you practice and finding out all the answers? Practice more? Okay, we're gonna do that.
Great.
Alright, I'm gonna make it littler. If you, like, when we go on break, like, if you have some specific questions, like, just come up here and we'll break down specific questions. Like, if you got one just completely wrong and you don't know why you got it wrong, like, come on up here. Alright, let's go, no, one more time. I'll let this one. that was the first step. We're gonna go back through the PowerPoint now. We're gonna practice the rhythms again. We're gonna talk about causes. We're gonna talk about treatment, okay? Yes. So let me go all the way back here before I get that. What is this? As you can already. Artifact. What does artifact mean? False readings. So let's say you have one of these on your patient. What do you do? Okay, they said still got it. Alright, so make sure they're not sweaty. It's not a hairy spot, you may need to shave, replace the pads, dry the skin off. So we do not read artifacts. We need to do some interventions to get a better reading. Okay, so good. Alright, so our treatments. Our goals of treatment are to optimize cardiac output. It's always the goal of treatment. Our priority is going to be assess, 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 assess. Is your patient symptomatic of this rhythm or not? How do you know they're symptomatic of the rhythm? Let's start what? Showing signs and symptoms of decreased cardiac output, so they look like they look like drop dead Fred. So we're gonna look at each one of these rhythms. We're gonna assess. Do you look like drop dead Fred? I need to do something about it. Do you not look like drop dead Fred? Cool. Hold on about my day. I got a lot of stuff to do. Okay? That's our first step. Is we're going to assess. Are you symptomatic or are you not? We're gonna look for causes, so we're gonna go through those because a lot of these rhythms can be prevented. So we're gonna try and prevent rhythms before they're even a problem. And then some of these, like AFib, people live in those. So we gotta have some long-term management for these. Most of them we're gonna try and get them out of, but like AFib, sometimes you're stuck with it. Alright, so let's start with this one. So what's the name of this rhythm? Sinus bradycardia. So you have a patient in sinus bradycardia, you see it on the monitor, you walk in the room, what do you do?
Ask for atrophy.
Assess. We're going to assess. All right, let's say my patient's asymptomatic. Is that possible with this rhythm of a heart rate of 40? Yeah. Who would have this rhythm and be asymptomatic? Yeah, people that have excellent cardiac health. So the better your cardiac health, and that's typically going to be your athletes, they have lower heart rates because they don't need to pump, they don't need to beat as much because their pump is so good. So we're going to assess. If they are asymptomatic, I'm going to say, good for you. I had a soccer coach in my class one semester, and his heart rate lives at 40. So he was fun during vital signs. Everybody was like, come on, we get 42. That's not right. He's like, no, my heart rate's 42. Let's pay attention. So asymptomatic, I'm gonna walk away. Symptomatic, I've got it here. So my first step, I want to try and figure out why are we bradycardic. So tell me some reasons people might be bradycardic. So what? Okay. Could be asleep, so but then I need to see if they're symptomatic or not. So let's say that they are symptomatic. What's the reason they could be bradycardic? Like what? 3. Opioids. Opioids cause bradycardia. Absolutely. What else causes bradycardia? A lot of our different heart medications, like our beta blockers or calcium channel blockers, those types of things cause some bradycardia. I heard somebody say anesthesia, that can cause some bradycardia. What else? There's another drug class, psych-wise. Benzodiazepines. So we've got a lot of different medications that cause bradycardia. Let's say they have overdosed on fentanyl. What do I do? Narcan. I'm going to treat the cause. Let's say they overdosed on, my grandmother used to do this. She'd forget she took her heart medicine and just take another one. And she'd forget, she'd just take another one. I'm just gonna have to get her through until that half-life wears off of the medication. So I've got a reversal for my benzos, I've got a reversal for my opioids, but if we took too much heart medication, I've got to bandage you through. My mother-in-law, when she was really sick, got down to 67 pounds, and her normal dose of her medication was too much for her because she dropped her weight so much. So she ended up having some bradycardic issues because of that. All right, what are some other reasons we may be bradycardic? Do what? Not too bad. That usually tends to cause those tachycardic issues. But if we want to say like Valsalva, like if you're straining really hard, that can cause some bradycardic issues. What did you pull out? Valsalva, like if they're constipated and are bearing down to try and have bowel movement, that can cause some bradycardia. What else? What's something else that can cause bradycardia? No, fluid overload is cause tachycardia.
ST no failure.
Do what?
ST no failure.
What are you saying?
No failure.
What?
The node, the pacemaker.
Oh, that's gonna be more like a heart block. So we'll get into heart blocks. So this one specifically, is that a big? What about lack of oxygen? Nobody hypoxia? Okay, where your O2 stat goes, your heart rate will follow. So SpO2 goes down, heart rate's gonna come down right on with it. Just takes a little bit longer. So hypoxia, so how would I fix that? Give them some oxygen. All right, let's say we've looked for a cause. We can't find a cause that we can easily correct right now. We don't know why they're in bradycardia, so we're gonna have to move on to pharmacological measures. So let me skip on down, just so I don't have to spell the drugs out for you. And I'll go back, and I don't wanna spell the drugs, so I'm gonna skip to this slide where the drugs are spelled. It's towards the end. So I've looked for all my causes, can't find a reversible cause. I'm gonna have to now go into pharmacological treatment. My first drug that I have listed up here is atropine. That is our first line drug for bradycardia. It's easily accessible. I can grab it at any time as long as you got an IV. I can push it on you because this is an IV push. So atropine stimulates the SA node. So that should decrease your heart rate.
Is it ever a drip or it's always a push?
It's always a push. Yes, it's gonna act really quickly, really fast.
What did you say?
The SA node. Alright, if I push atropine, what am I worried about? I'm worried about swinging the pendulum in the opposite direction. I'm worried about tachycardia. It almost always causes tachycardia. It does have a short half-life, so it's gonna wear off pretty quickly. But, yeah, we usually go from a heart rate of 40 all the way to 140. That's kind of expected. But we would like to try to avoid that if possible. A lot of times we don't even have to give the whole dose. We can give part of the dose and their heart rate will come on up and we're like, ooh, good, stop. We don't want to swing too far. But it is an IV push. As long as you got a good IV, it's gonna work just fine. It is a Band-Aid though. It's got a short half-life, so it's gonna wear off. And what can happen when it wears off? We can go right back down into bradycardia. So we have some other choices. We have dopamine and epinephrine drips. These are vasopressors. So these are a continuous drip, so there's gonna be very tiny, very small doses continuously. And we can titrate those to the heart rate, so I can turn it up if I need their heart rate to come up a little bit more. If they swing tachycardic, what can I do? Titrate it back down and try and hit that sweet spot to where they are in a good rhythm. Alright, this is also kind of a Band-Aid fix until I can figure out why are you bradycardic? What's going on? So all these have electrical options. We can pace this person. We've got 3 different ways we can pace. So there's 2 different ways to temporary pace. So we can do transcutaneous. What does that mean?
On top of the skin.
On top of the skin. So I just put the pads on the chest and I can pace through the skin. We also have a temporary pacer like they can place in the cath lab. Like I told you guys, they can go in through the groin site, run the wires up into the heart, and temporary pace that way. And then there's a permanent pacemaker. You guys have y'all seen a patient with a pacemaker before? Or know somebody with a pacemaker? Huge. Alright, so we usually see the little pacemaker under their skin. So we'll talk more about pacemakers just a little bit. But
Does the temporary one go through an artery?
yeah, it goes they place it in the cath lab. So it's the exact same procedure as a heart cath. They just leave a pacemaker wires in place temporarily. So a lot of times they do the temporary, like if we know, or we know a reason and it's a temporary reason they're in bradycardia, they'll do a temporary. Or if they know, hey, we're gonna have to have a permanent pacemaker, they'll do that while they're waiting to, get everything set up to do the permanent one. So pacemakers are for bradycardia only. Okay, that's the only time you see that word pacemaker on this slide, right? On the bradycardic slide. So if you have a pacemaker, can your heart rate hit 120? Nope, the pacemaker's not gonna do it, but your own heart can. Like if you decide to slam 3 energy drinks, plus drink some coffee, yeah, your heart rate can get on up there. And the pacemaker is just gonna be like, cool.
It's not like they're beside it, like it's their right.
Correct. Pacemaker only works if your heart rate is below its set limit. So we typically set pacemakers at 60 or 70. And if your heart rate drops below that, the pacemaker's like, I'm here, I'm gonna work. If your heart rate goes up above it, it goes, all right, have fun. I'll be here if you need me. That's how pacemaker works. Only fires off an impulse if it's needed.
So you can see a high heart rate, like 120, but you're not gonna see a heart rate of like 50.
Correct. Yeah, if you have a pacemaker, you should never go below your set rate, which is usually 60 or 70. Absolutely can go up. Some different. So pacemakers can do a whole lot of things, but just for bradycardia, just a base pacemaker with no frills, no bells, no whistles, just gonna treat bradycardia. Alright, so we'll get out of that slide. So we know how to treat bradycardia. Alright, get out of that slide, and then we'll go back to where we were. Alright, so we know what causes sinus bradycardia, we know how to assess sinus bradycardia, and we know how to treat sinus bradycardia. We good with that? Any questions? Okay. So now let's look at, this is our sinus tachycardia, right? Alright, so you look at your monitor, or you get your report, and your patient is in sinus tachycardia. What's the first thing you do? Thank you so much. Y'all have learned. I appreciate that. You assess. How do you know if they're symptomatic? Alright, they're showing symptoms and they look like our drop dead Fred. Alright, if I walk up those stairs, all 3 flights, guess what I'm in? Sinus tachycardia. Am I symptomatic? Like just a little bit, maybe breathing a little hard, maybe a little out of breath, but if I sit down, it'll get better. Yes, because y'all do this too. Y'all take the stairs. You sit down and you catch your breath. So that's going to be asymptomatic. So everybody goes into some tachycardia when we get a little bit of exercise. As long as you rest and it resolves, you're good. That's gonna be asymptomatic. If you have severe symptoms, like our drop dead Fred, like you're gonna pass out because you exercised, that's symptomatic. We gotta deal with that. Alright, so what are some things that cause tachycardia? Signs of tachycardia. Alright, anxiety. What else? Dehydration. Exercise. So this is why we always say you need to check with your healthcare provider before you start an exercise regimen, especially if you're having some heart conditions or, you know, are pregnant ladies, you know, a change in your health status. Alright, what else do we say? Medications, because we can always swing the pendulum the opposite direction and have some of those issues. We've got some fun drugs that cause tachycardia. What are those? Stimulants. So we've got prescription stimulants, and then we've got, you know, cook up on Sand Mountain stimulants, and then get out on the street downtown and get you some cocaine stimulants. What's a stimulant that you can drink? Caffeine. You drink too much energy drinks. You drink too much caffeine coffee. Tachycardia. We said fluid volume deficit with dehydration, fluid volume overload. We learned about that with functional ability, right? So we got a lot of reasons to have tachycardia. Fear, anxiety, stress, all of those things. So what do we do? Alright, so we're gonna have to address the cause first. If somebody is having a lot of anxiety, I don't wanna go for cardiac meds. What do I need to go for? Maybe some anxiety meds, maybe some deep breathing exercises. Like, I need to look at the cause. We don't just jump straight to meds. So we need to look at the cause. What can we do to affect that? Are they dehydrated? Give them some fluids. Alright, are they fluid volume overloaded? Give them a diuretic. So we're gonna have to treat the cause. You see a pattern here? Assess, look for the cause, treat the cause. Alright, so now that we talked about that one, let's go back to our slide with the treatment slide. Alright, we're gonna say that we looked for a cause, we can't find a cause, or maybe we tried to fix the cause and it didn't work. So we're gonna have to intervene elsewhere. So we've got our medication. So our first line medication is adenosine. Beware, the first line medication for bradycardia starts with an A. The first line medication for tachycardia starts with an A. Beware of the A names. Don't get these mixed up. So adenosine is our first line treatment for tachycardia. So let's talk about this. This is a IV push medicine. This one is fun because it is going to reset or reboot the heart. Means it's going to shut it down and bring it back up. So for this one, if I ask you to do an IV push medication, what's the standard answer when I ask you in clinical? How fast are you going to push the medicine? Push it slow. You're going to push it over 1 to 2 minutes. If it's one of these others, we'll talk about in a minute. You're going to push it over longer. With this one, you get to break that rule, and you are going to slam it as fast as your little fingers can push it. And then you're going to flush it as fast as your little fingers can push it. Because the half-life of this medication is less than 10 seconds. So it is the epitome of wham, bam, and I'm out. It's gone. No, but I didn't want to finish that one. You get the point. All right, so we're gonna push adenosine super fast. Do I want it in an IV way down here? No, it has less than 10 seconds to get to the heart. Where do I want an IV? Yeah, I want up here. Central line is great. There is different dosages for a central line versus a peripheral access. I'm not worried about y'all know that. That's very much an ICU level knowledge or an ER level knowledge. So, but we're going to give adenosine. We want a good IV access that's close to the heart because we only got less than 10 seconds to make it there. Okay. All right, adenosine is a reboot. So you are going to see your heart rate go from 180, 200 to 0 for less than 10 seconds. And then hopefully come back up in sinus rhythm. That's it. Medication works perfectly, and that's how it's supposed to happen. Doesn't always work. You can give it up to 3 times. The dosages is going to change with those 3 times. Again, don't worry about learning the pattern. But that's your limit. You can give it 3 times. What equipment would you like to have with you when you give this medication? All the emergency equipment. You also do need to have a healthcare provider there with you. You don't give this on your own, but you want somebody there in case the worst were to happen. We need to have all the players in place, all the equipment in place in case the worst happens. If you do a rotation in the ER and you do more than a few days, I can almost guarantee you are going to see adenosine given, because people come in the ER all the time with unexplained tachycardia. We give them adenosine and it fixes it. So it's extremely common medication in the ER. How do you think this person feels when you give this medicine? Horrible. They hate it. Their heart's stopping. They're going from 200 to 0. It feels awful. So I don't tell people, hey, I'm going to stop your heart for a minute. That's terrifying. But I do tell them, you're going to feel awful, but I'm right here with you. It's going to be less than 10 seconds. I'm not going to leave your side. All right, let's count down. All right, and it's going to be over in, all right, and we're done. Okay, like it's literally like that.
Was it just exciting or?
The heart went from 200 to all of a sudden it's like, because you can feel your heart pumping fast, all of a sudden your heart's not beating. It's a horrible feeling. Your cardiac output is just, it was low, then it's 0, and then all of a sudden it pops back up. It's a terrible feeling. People all the time, they're like, don't do that to me again. Sometimes we have to. So, but it works great. So it is a medical cardioverting medication. So if you've heard the word cardiovert, we normally do that electrically. This does it pharmacologically. So it's going to cardiovert patients. All right, let's say maybe adenosine's not indicated for the situation. It's not a good choice. Maybe we tried it, it didn't work, because sometimes we push it and we're like, that happened. So we got to go to something else. We have some choices. We have antiarrhythmics. Lidocaine and amiodarone are both antiarrhythmics. Those are drips. Those are medication drips. Those have very specific protocols that you don't have to know. But those are drips. We have beta blockers. We have calcium channel blockers. Am I talking about a pill beta blocker or a calcium channel blocker? No, not when I have a symptomatic person in tachycardia. We're going to do an IV push of a beta blocker or a calcium channel blocker. We do have IV drips in these medicines as well. So this, so on each side with all these medications, these are great select all that apply type questions. They are not priority questions. Okay? You are an entry-level practice nurse. You are required to know which category these meds belong in, but it is a nurse practitioner scope to decide which one works best for which situation. Okay? So you do not have to know first line, second line, third line, or this one works better for AFib, this one works better for sinus. Like, you don't have to know any of that. You just need to know bradycardia, these are my meds, tachycardia, these are my meds. So more think select all that apply, not putting them in order or prioritizing them. Okay? All right. So if I am given one of these over here, an IV beta blocker or IV calcium channel blocker, how fast am I pushing that? Slow. These are the ones that are more like 5 minutes. And you may not even get all the dose in.
Do we have amiodarone in pill form and stuff? I remember pill form.
Yeah, we have amiodarone in pill forms, either Pacerone or amiodarone. So people can take that checking the blood pressure before, during, and after, because all these medications, what do they do to blood pressure? It drops, because most people take these for high blood pressure, right? It brings their blood pressure down. So there's plenty of times where I was ordered to give 5 milligrams of metoprolol IV, and I could only give 2.5 because their blood pressure bottomed out. I had to stop. So that's why I say do your blood pressure before, during, and after. I've had to give diltiazem, which is a calcium channel blocker. Could only give half the dose because their heart rate just went up. So we're gonna worry about bradycardia, we're gonna worry about hypotension. When we're pushing these, we're gonna do it very, very slow. So adenosine, we're gonna slam it. All the other ones, we're gonna do very, very slowly. And we're gonna be watching that heart rhythm. If you have a beta blocker or a calcium channel blocker, what is a rhythm you are at risk of being put into?
Block.
A heart block. So we're worried about bradycardia, but we're also worried about putting them into a heart block. Because it's literally what they're doing. They're trying to block out some of those impulses. So that's another reason why we push it slow. We monitor the rhythm. Alright, then down here, we also have electrical options. So some of you guys get to see a cardioversion in the cath lab? Seen a few little head nods. We can cardiovert several different rhythms. We can cardiovert a tachycardia. The word synchronized means that we are going to set our machine to sync to the R wave. So that means I'm gonna hit my little button that says sync. And when I hit the charge and deliver a shock, or cardioversion, it is going to send that shock on the R wave. Now, it really doesn't matter that I'm sending it on the R wave. What matters is that I do not deliver a shock on the, what wave? T wave. Because what can happen if I shock on the T wave? Oh.
On the R wave.
Flutter. Nope.
Send in the beat.
R on T phenomenon sending into V-tach. I don't want a pacemaker spike on a T wave. I don't want a PVC on a T wave. I don't want to deliver a shock on a T wave. I don't want to do anything on a T wave because I can send my patient into V-tach. So the word synchronized means I'm going to set my machine to deliver that shock on the R wave. It really don't matter. It's just I don't want a shock on the T wave. And there's literally no way you can time that in a human fashion. Impossible. So you've got to set your machine to look for it. Defibrillation is also a shock. So the difference between cardioversion and defibrillation. Cardioversion is going to be what we do on this test. Defibrillation is what we're going to do on the medical emergency test. So a cardioversion is elective. We're going to use joules as our unit of measure for electricity. We're going to use a small amount of electricity. This person is awake. They're having some rhythm problems. They're tachycardic. They're probably symptomatic, but they're stable. They're not in crisis. They're not in trouble. We've got time to give them some sedation. We've got time to get an informed consent signed. Like everything's, we're just trying to get this rhythm fixed. So small amounts of electricity, stable, controlled situation. If you hear the word defibrillates, this is going to be lethal rhythms. We are turning up that electricity up to the max. We're giving a big shock. This person, as you can see with our little X's here, they are, for all intents and purposes, dead because we were trying to resuscitate them back to life. So when you hear those two different words, cardioversion and defibrillation, they are both shocks, but one's going to be for our stable patients, dysrhythmias, we got time to sedate them, we got time to get informed consent. Defibrillation, this will be medical emergencies, this is for lethal rhythms only. Okay, so it's the difference between those two words. Alright, questions on tachycardia?
those in the calcium channel and the
Alright, well, let's take a break and then we'll come and we'll get through the rest of our rules. Alright, what's this rhythm? SVT. SVT. So it might be AFib, but it's too fast for me to tell. So it's very tachycardic. So the rate's super high. I can't tell if I've got a P wave or a T wave. It's just too fast, but my QRS is look good. So this is SVT, supraventricular tachycardia. Alright, so I have a patient in SVT. What's the first thing I do?
Assess.
Very good. Assess. Are they symptomatic or not? They're probably going to be symptomatic. This is really high. Unless they're doing like high intensity exercise. But I learned my vision starts to go darker around the edges when my heart rate's about 185. So tone it down. Learn that. I don't get up that high anymore. That was one of my best. But so they're symptomatic. What do we do? Find the cause. What's going on? When my heart rate would get high and my vision would start getting dark around the edges, what do you think I did? Like calmed it down. Decrease the intensity of exercise. Calm it down. What if it's medications? Try and see if there's a reversal. This could be way too much caffeine. This could be fluid volume overload, fluid volume deficit. Gee, am I saying the exact same things I said for sinus tachycardia? Yep, because guess what? There's no difference in the treatment. We're going to treat it exactly the same. The only thing I left off with sinus tachycardia, which we've kind of already talked about, but I want to make sure that we add it to it. What's the non-pharmacological, non-invasive intervention we can try to do to slow a heart rate down? Yeah, bear down and do the Valsalva. So we left that off with our sinus tack, so make sure you add that in. Sorry, we'd already talked about it, so I just went right over by it. But your treatment for SVT is the same treatment as sinus tack. There is no difference.
Where would you put the Valsalva maneuver under like a treatment? Or
So I would do that before I did medications, because it's a non-pharmacological, non-invasive, so we know we always do least invasive to most invasive. So I would put that kind of early on in the beginning. All right, we're gonna talk about AFib and A-flutter. Do not separate these when learning about how to take care of it and things like that. AFib and A-flutter, we treat exactly the same. AFib, we've got that chaotic baseline. A-flutter, we've got the sawtooth baseline. Alright, with AFib, what we learned about last week, what are the two things? Well, actually, let's go back to cause. We really don't know why people go into AFib. They just do. This is a very common dysrhythmia. It's much more common as we get older. So, kind of an age-related type situation. There are some causes for it, but nothing really like definitive. So, AFib just kind of happens to be older. Alright, so what are the two things somebody in AFib or A-flutter is at risk for based on what we know about this rhythm? Blood clots. So what do they need to take every day? Some sort of anticoagulant. Very good. What is the other thing they are at risk for? Going into tachycardia for no reason. So PE, we're going to go, that's blood clot. So PE, stroke, heart attack, those are all blood clots. So they can go into tachycardia for no reason, remember? That AD node can just decide, I'm going to transmit all y'all, so they can be sitting on the couch and just suddenly go into tachycardia. So what do they need to take every day?
Maybe a beta blocker?
one of those every day. So an AFib, A-flutter patient is going to take 2 medicines every day if they stay in AFib or A-flutter. And those 2 medication classes are what? Anticoagulant or blood thinner, and something to control their heart rate, whether it's antiarrhythmic. One of these, even though they're antihypertensive, they still work as an antiarrhythmic as well. All right, let's say my patient, let's see, where's my AFib at? Let's say my patient is not a good candidate for a blood thinner, or they just don't want to live in AFib, because AFib, you have a risk of blood clots. So even though you take a blood thinner, you still can have a blood clot. So those types of things are going to be like what I said, like you can have stroke. AFib is the #1 cause of stroke, #1. If you ever listen to the actual radio, if you don't listen to Apple CarPlay, which I don't know, there are some ads on Apple CarPlay too. There's ads on the radio all the time about #1 cause of stroke is AFib. Are you an AFib? Have you ever been diagnosed with AFib? Make sure you take your Eliquis. I was trying to hawk those blood thinners. So they're at risk for stroke. That's the biggest risk. Smaller risk is going to be the blood clots elsewhere, like pulmonary embolism or a heart attack. Those are not too often. It's just based on anatomy. When you shoot a blood clot out of your heart, it's going over that big hump and it just goes straight up to the brain. You can also throw blood clots to your extremities. You may have ever seen a blood clot in an artery in an extremity. It's pretty rough. So if you throw a blood clot in your artery, because it's going to come out of the aorta and go down to your artery, and you throw a blood clot to your leg, what symptoms would you see in that leg?
Swelling, redness.
Y'all are thinking DVTs. I said artery. You throw a blood clot in your artery to your extremity, to your leg.
Pale.
Pale, because is blood flow getting to it?
Okay, check.
Cold. Are you gonna get a pulse?
No.
No pulse, because you haven't, your artery is blocked. So lose a pulse. Cold. Pale. What happens when tissue don't get blood? It dies. Is that painful or not painful? Extremely painful. So don't get the signs of DVT, because that's what y'all are just so used to, which is the swelling, the redness, those types of symptoms. That's a clot in the vein. When we have AFib, we're at risk for a clot in the artery, which means no pulse, cold, pale, sudden pain. So with AFib, we're going to have to protect against that. Protect the whole body from a blood clot, and there's multiple places the blood clot can go. So they're going to have to take an anticoagulant every day. They can do heparin shots, or they can take a Eliquis pill, or there's a lot of different ways to do that, but they're going to take some sort of anticoagulant. We need to prevent tachycardia, because AFib loves to go into tachycardia. We call it the RVR, but they can go to a heart rate up to 200 for no reason. This is why you see a denizen like all the time in the ER, because when the heart rates are that high, we just got to slow it down. We may not know what it is, so we got to slow it down. So AFib, A-flutter, treat them the same. Which one's the sawtooth? 11. Okay. All right, there is a way we can cure AFib. So, but if we can't cure it, people just stay on those medicines for the rest of their life. But we can cure it. There is what we've already talked about, an electrical procedure that can get you out of AFib back into sinus rhythm. What was it? Cardioversion. So we can cardiovert people out of AFib back into sinus rhythm. So if you saw a cardioversion in the cath lab, I can almost guarantee you it was because that patient was an AFib or AFib. Prior to the cardioversion, what test did you see being done? You saw a TEE. Why did you see it? Why do we have to do a TEE before we can do a cardioversion? Because we have to check for blood clots before we cardiovert. So if you're sitting here, so if we've got our atria just sitting up here quivering, and blood blood is just pooling, a clot can develop, right? You cardiovert and the patient goes, what happens?
Throw the block.
You're gonna throw the blood. So we're gonna do a TEE, cause that's our best picture. We're gonna do a TEE right before we do it. Not everybody has to have a TEE, so my dad didn't have to have a TEE before his cardioversion, because they sent him home on an anticoagulant for 2 to 3 weeks, and so he was anticoagulated enough that they did it without the TEE. So, either way, we gotta make sure there's no blood clots in the heart, whether you're fully anticoagulated or if we do a TEE. So, no blood clots in the heart before cardioversion. What's the word that we're gonna do? It's a what type of cardioversion? Synchronized. And what does the word synchronize mean? We're gonna shock on the R wave because we do not want to shock on the T wave, because what can we throw our patient into if we shock on the T wave?
V-tach.
V-tach. Very good. Alright. Let's look at these PVCs. PVCs are normal. You guys have them all the time. Before a test, you have them more than you have now. Some of y'all may be having a lot of them right now because you don't like learning all this stuff or you're anxious about it. PVCs are normal. Unifocals, occasional unifocal PVCs. We increase our PVCs with more stress and anxiety, fear, things like that. We start getting dangerous PVCs, frequent, multifocal, or ones where they start pairing up together. In what situation? What would cause some dangerous PVCs? What do you think? Very good. Electrolyte imbalance. So potassium changes, highs and lows. Calcium, mainly low calciums, because we get a real irritated heart when our calcium is low, it's calcium calm. Sodium, not quite so much, it's mainly our potassium and our calcium issues that cause PVCs. What do we drink that can cause a PVC? Caffeine. Caffeine causes a lot of PVCs. So I'm worried about these mainly when they're electrolyte based because I need to correct those electrolyte imbalances. So I'm going to, same thing, I'm going to assess and I'm gonna look for ways that I can reverse, so if I can correct some electrolyte imbalances. Sometimes fluid volume overload and fluid volume deficit can cause these as well. So I can correct my hydration. And then otherwise, if we're having dangerous levels of PVCs that I can't correct, we can give them one of those antiarrhythmics. Because I want to prevent them from going into a lethal rhythm. We'll treat all those next test. We don't want this to happen. This would be somebody I would put on an antiarrhythmic. I don't know, I guess amiodarone has got better paying reps right now because amiodarone seems to be the buy one get one free of all doctors and hospitals right now. But I'm starting to see some resurgence of lidocaine here lately. So I don't know, maybe lidocaine got some better reps too. But it really just is who's got their drugs out in front of doctors more often on which one they choose. Lethal, recognize it, we're not treating it. Lethal, recognize it, we're not treating it. Same. Pacemakers, what do we need to know about pacemakers?
It should be on a P-wave or
Should be in front of a P-wave, in front of a QRS, and it should never be anywhere else. It treats, which one, bradycardia or tachycardia?
Bradycardia.
Bradycardia. If you're tachycardic, what's it gonna do? It'll chill out and sit in the background and let you deal with your tachycardia situation. Heart blocks. We are going to treat a heart block if it is bradycardic, like we treat bradycardia. That's as far as I'm going with heart block treatment. Most times, if we have people in sustained heart blocks, like it's not due taking too much medication, like there's something going on. Heart blocks a lot of times are caused by inflammation, so like myocarditis, endocarditis, lupus, any type of inflammation going on in the heart. It could be trauma to the heart, like a heart attack. You got That's okay. Trauma to the heart, so heart attacks, heart surgeries where there's a lot of scar tissue. So heart blocks can be caused by things like that. Most times if it's a heart block that's staying and our patient is being symptomatic, they're gonna have a pacemaker. So we can treat our bradycardia just like we treat any other bradycardia to get them pretty much stable for a pacemaker. And that's it for treatments. How do we feel on treatments? Okay. Pretty much bradycardic treatments, tachycardic treatments, add the AFib and A-flutter, got some little nuances to them that we gotta know about. And then we're gonna do all the lethal treatments later. So, with that being said, now that we've learned about all of our rhythms, y'all can watch my fun video. You can't watch my fun video, and I should have pulled it up on my phone. Alright, so the only rhythm I have not taught you guys that they do in this little heartbeat dance is junctional. So junctional is just where there's no P wave. So it's a little slower. And then they kind of do some specifics with one or two of the heart blocks, but you'll figure that out. But it's a fun little video. Hopefully I have audio working. They're not testing This is so like a med school project. It's the friend that didn't want to be in the group project. Pretty sure this guy wrote this. He's real excited. magnesium. So that's my fun little video. Yes, it is very old, but it still works. There's a lot of people that have remade that video. I just like their giggly little music. Alright, how do you feel about this rhythmias? Kind of, sort of, maybe? Yeah, good? Alright, well, am I done with this PowerPoint? I think I'm done with that PowerPoint. We're done with that one. Let's look at heart failure. So we'll start, we'll go over kind of the basics with heart failure, and we'll take a break and come back and finish up with heart failure. Okay, so heart failure. So there are a lot of different stages with criteria for heart failure. So we're just gonna kind of stay pretty surface level, like pretty basic, because 114 is basic heart failure and 211 is advanced heart failure. So we're sticking to the basics. So heart failure is gonna be failure of the heart to pump blood effectively. So our signs and symptoms are gonna range depending on what the problem is and which side of the heart is not working. So this is why it's extremely important. You have to know which way the blood travels through the heart. So we go from the right side of the heart to the lungs, then we come back to the left side of the heart, and then to the body. So we have to know that. If you get that mixed up, you're gonna get all the signs and symptoms mixed up. So you have to know blood comes from the body to the right, then to the lungs, to the left, out to the body. So there's gonna be these various stages of heart failure. So risk for heart failure is going to be, we have all of these risk factors. So this just looks like poor lifestyle choices, right? So a lot of physical inactivity, obesity, are terrible American diets because we like to have fast, quick food that is full of horrible stuff that our heart doesn't like. Lots of sugars. We have diabetes is on there. Cigarette smoking. So just all of our poor lifestyle makes our heart work very hard. We're putting too much workload on the heart. So at risk is going to be lifestyle choices. Pre-heart failure is where we're going to have structural changes, but we're not seeing it yet. So remember, our body's great at compensating. So that's our pre-heart failure. We're starting to have changes in our heart, but we're still able to compensate, and we don't have symptoms yet. Heart failure, this is where we're going to get into those different signs and symptoms, because we've got systolic heart failure, diastolic heart failure, we've got right and left. So that's going to be on the next slide. We'll get into the differences with those. So we have symptoms at this stage. And then advanced heart failure, this is where our symptoms don't respond to treatment. This is going to be more 211, like when you start going into shock, stuff like that. So we're going to stick in this heart failure world. So I updated this slide this morning. That's why I was a smidgen late, because I wanted to add the terms up at the top. So if you've got the older slide that I didn't post this morning, all I did was add those terms up there. So we've got two different types of heart failure, because it depends on what's actually going on with the heart. So if we start over here, which is diastolic, the kind of new term that we're using now is heart failure with preserved ejection fraction. So what's an ejection fraction? The percentage of blood that is pumped out with every single heartbeat. And what should that be? 50 to 70%. So preserved, ejection fraction, you still have a pretty good ejection fraction. The problem with this is that the heart can't fill because the muscles have gotten enlarged, thickened, hypertrophied. Some reason we've got thickened walls. So do you see we do not have a lot of space to fill up with blood. So the heart just can't open up. So our heart gets non-compliant. It doesn't stretch like it's supposed to because we've got those thick walls. So that's one type of heart failure. Another type of heart failure, and by far this is the most common type of heart failure that we see people coming into the hospital with, because this is our heart failure with reduced ejection fraction, so that means their ejection fraction is going to be less than 50%. They're going to show us a lot of signs and symptoms, but this is where their heart can't pump, so it doesn't have good contractility. So the heart's overstretched. Remember we talked about that rubber band theory, where you stretch and you stretch and you stretch a rubber band, and if you overstretch it, it won't come back to its original shape. So this one, you've got this overstretched heart, and when it tries to beat, it's just like, we need it to beat. So we're gonna have less than 50% ejection fraction. Definitely gonna see symptoms.
So the systolic is the most common.
That's what we see in the hospital, is these people are gonna be having a lot of symptoms and a lot of problems. This one we don't see quite as much because they have an ejection fraction that's over 50, so they're functioning pretty well. This is by far what we see. This type of heart failure, a lot of times this is due, again, those risk factors. So if we're obese, if we weigh 350 pounds at 5'8", that's a lot of weight to carry around. Your heart is gonna be working overtime. If you have hypertension, your heart's gotta overcome that afterload. It's gonna be working overtime. So we're stretching and stretching and stretching and stretching that heart to where it finally just is boggy and it can't return back. So boggy uterus, boggy heart, neither one of them are good. We don't like it. So our heart is supposed to pump blood forward. 50 to 70% of our blood is supposed to go forward. Let's say only 20% goes forward. So if only 20% goes forward, where's the rest of it going? It's backing up. So if we have left-sided heart failure, it's backing up to the lungs. So think left lungs. Left-sided heart failure, left lungs. That's where we're gonna see our symptoms. If you put all those signs and symptoms together, what's this person dealing with? Pulmonary edema. Yeah. That's all pulmonary edema. Every last bit of it. So they have the restlessness, they can be confused because they don't have good oxygenation, orthopnea, they can't lay down, they gotta sit up. They're tachycardic because they can't breathe. Exertional dyspnea, they can't walk without getting out of breath because their lungs are full of fluid. Cyanosis, and then all of the crackles. We can have wheezes too because of just exertion, like working really hard. Coughing, blood tinged sputum, all that stuff we learned about with functional ability. Don't worry about the pulmonary capillary wedge pressure. That's a like ICU 211 type hemodynamic monitoring because we're not going there. So, but everything looks like pulmonary edema. We just can't breathe because our lungs are full of fluid. As opposed to right-sided, so if only 20% is going forward on the right side, where's all of it backing up to? It's backing up to the body. So think left lung, right rest of the body. So that's where your symptoms are. Left side of heart failure, lung problems. Right side of the heart failure, rest of the body. So all our fluid is gonna be stuck out in our extremities. We're gonna be very edematous, very puffy and swollen. We're gonna have enlarged organs, so an enlarged liver, an enlarged spleen, because blood is not able to get out of it clogging up everything, cause it's old, it's venous, I don't want it. So they get a lot of GI issues. They don't wanna eat just because their guts don't work as good as they should, cause they're not getting good arterial perfusion. They may have, or they do have a lot of weight gain, they may have ascites, and the ascites is not really related to liver failure, it's just related to that blood is just backed up and it's just, the fluid's gotta go somewhere. So it can be in the abdomen and get ascites. So it can be due to liver failure, but it also could just be due to heart failure. So left lung, right, rest of the body. Make sense? Alright, so what are we gonna do about it? So I left this slide up here so you have it when you get to 211, but for 114, we're gonna go up into the surgical aspect, and then I'm gonna leave all this for you guys to have for 211. So when you get there, you'll have something to look back on. But kind of draw a line in the surgical, that's where we're gonna stop. So the general measures, the medications will be 114. All of this other stuff is what you're gonna be doing in 211. So for us, we're gonna treat the underlying cause or precipitating factors. What were those? Obesity, lose some weight. Hypertension, control it. Smoking, quit it. Diabetes, stop eating so much sugar. Control your diabetes. So we're gonna work on those causes, those risk factors, to try and decrease the workload of my heart. So good, healthy lifestyle choices. All right, so we see on there diet modifications. So those are related to, just good hypertension control. So possible fluid restriction. So the fluid restriction helps work on our precipitating factors, but it also helps us because we're not able to get rid of our fluid like we're supposed to. Adequate rest. They're going to get out of breath with the physical activity for different reasons. So left side, they're going to get out of breath because they can't breathe. So they need a lot of rest. Right side, they're going to get out of breath because they're lugging out a whole lot of fluid, excess weight on them. So it's hard to keep up. That works out their heart. So they need adequate rest. They need exercise. This is where we always tell people, again, make sure you talk with your healthcare provider before you start an exercise regimen. So we want to make sure you're safe. This is why we have a whole lot of pulmonary, like cardiopulmonary gyms. So if you go to 119, St. Vincent's UAB, there's a whole gym in there, and they've got people working there at crash carts. So, they're monitoring the people working, because it's a cardiopulmonary gym. We already said, smoking cessation, adequate oxygen. Which side really needs the oxygen, left or right? A lot of the left. Yeah. And then just general health maintenance. All right, medications. This is where we kind of get into our heart failure treatment even more, other than just lifestyle choices. Diuretics. Why diuretics? Help get the fluid off. All right, we want to help decrease. Is this going to decrease preload or afterload?
Reload.
Preload, because preload is a volume. So I want to decrease my preload. So we do diuretics to decrease the preload, to take work off of the heart. But then we also want to decrease the afterload, which we use with ACE inhibitors. Because what does the ACE inhibitor do? Like literally, what does ACE stand for? Angiotensin converting enzyme inhibitor. So it's going to stop that cascade from angiotensin 1 to angiotensin 2, which makes your blood pressure go up. So we're trying to stop that process because we want to decrease that afterload on the heart. So we're going to do diuretics, decrease preload. We're going to do ACE inhibitors to decrease afterload. So that way we're working on both sides to try and decrease the workload of the heart. ARBs, those are really what we go to when ACE inhibitors, your patient can't tolerate them. So we're going to do our med activity this afternoon, so somebody will have to be in charge of that. Beta blockers, are they going to decrease preload or afterload? They're going to decrease some afterload for us because they're going to lower that blood pressure. Also going to help lower the heart nitrates are vasodilators. So vasodilators are gonna do what for preload or afterload? Afterload, because it's gonna help open up those vessels more so that the heart doesn't have to overcome as much. So, if you'll add nitrates to that, because we want a vasodilation effect. So we're trying to work on both sides. We're trying to work on preload, we're trying to work on afterload, all to decrease the workload of the heart. Patients can get better, especially if they make those changes, like, stop smoking, lose weight, handle their diabetes and their hypertension. They can absolutely get better. The problem is, people don't wanna do them choices and just keep doing what they do. And then they just continue to get worse. And then we see patients coming in, readmission after readmission after readmission after readmission. Heart failure can also occur after having damage to the heart. So when we talk about coronary artery disease here in just a little bit, that can also cause some heart failure because the tissue dies. But for the most part, it's gonna be all of those risk factors over here that are gonna cause heart failure. And that's heart failure in a nutshell. How we feel about that? Alright, what arrhythmia, if left unchecked and continues to go, can cause heart failure? I'm trying to pull two things together here. So, pick just one of those words. So, any of those tachycardias. If we have sustained, untreated tachycardias, it will lead to heart failure. So, AFib, that you don't take your antidysrhythmic, and you constantly have tachycardia issues, heart failure. So any tachycardia that's just kind of left unchecked and it's a pretty normal part of your life, at risk for heart failure. Bradycardia, not so much. So that's how, I just wanna make sure that we know the electrical system is over here, the pump system is over here. We can have some crossover that causes one or the other. Heart failure can cause some dysrhythmias, but it's more likely the cause of tachycardia issues. Okay, any questions? All right, let me pull up, so y'all give me like just a second, because I didn't get it pulled up before. numbers that we talked about before. So if he has reduced ejection fraction, we're expecting a low ejection fraction, so that's why he's gonna be decompensated. He has experienced 3 readmissions in the last month to manage his exacerbations, so that's not good. Oh, I skipped a line. His last echocardiogram revealed an ejection fraction of 20%. So what do we think about that? That sucks, really bad. There's no other word for that. It just sucks, because what is our ejection fraction supposed to be? 50 to 70. So he's only got 20% of the blood from the left side going forward. So he is going to be having what types of symptoms with a left ejection fraction of 20%? He's gonna be having lung symptoms. In addition to that, so he's gonna be having the lung symptoms, that's what's gonna be bringing him in here, because they said he's short of breath. How's his kidneys gonna be working?
Not being produced and all that.
Not being perfused, what are they most likely gonna be going into? He's gonna have some pre-renal AKI issues, because only 20% is going forward. So he's gonna have some issues with his kidneys too. He was direct admitted to the ICU because of signs and symptoms of severe dyspnea and orthopnea. So there's our left lung, he can't breathe. Upon auscultation, we've got crackles, G-shock. His respiratory rate is 22, that's actually kind of low, might actually be even higher. His SpO2 is 92 to 94, but he's on 4 liters of oxygen, nasal cannula. So he's requiring oxygen to keep just that pitiful 92 to 94% O2 sat. He got 80 milligrams of Lasix furosemide over 2 minutes. So why do we give him Lasix? We're trying to get that fluid out of his lungs, trying to get him to breathe a little bit easier. He reported some improvement with the shortness of breath after the furosemide administration. We gave him a Foley catheter because we want to assess his hourly intake and output. His urine output is 150 mLs over the last 3 hours. What do we think? That is not good, because that's barely the minimum that I want. So did he really respond to that 80 milligrams of furosemide? Unfortunately, not really. I need a whole lot. If you give me 80 milligrams of furosemide, I'm gonna have to drink that cup about 20 times over the next 3 days. I'm gonna lose so much fluid. So that's showing us what about our kidneys? Yeah, we're starting to have some of those AKI issues. He should have so much more fluid come off of him with that. Blood pressure is 156 over 88 and heart rate is 98. What do you think about that? Yeah, showing us fluid volume overload. What's his heart gonna be doing with fluid volume overload? Yeah, he's working really hard, so this is just increasing the problem, increasing the workload of his heart, just kind of making everything worse. So it's kind of like a vicious cycle. That all of his symptoms are making his heart work even harder, which is making his heart fail even more, which is causing more symptoms, and we're just stuck in this loop of garbage. He's oriented, doesn't have any pain, but he is short of breath. Again, shocker, because the Lasix didn't really work for him. And that's his symptoms. So let's go meet him. What are the top, as you care for your patient, what are the top complications that are most at risk for? We get to pick 3. So, yay or nay? Acute myocardial infarction? Fluid volume overload?
Yes.
Yeah. Fluid volume deficit? No, because that would be dumb to pick both of these, wouldn't it? From test-taking strategy management, don't pick opposites. One or the other. Decreased cardiac output?
Yes.
Absolutely. Severe dyspnea?
Yes.
Yeah, let's see how we do. Yay! Good job. Alright, we already read all that. Let's see what our orders are. to all this other fun stuff. So AFib and heart failure like to live hand in hand. They just like to go together. So a lot of times we see both of these. So this is a very typical patient that you would see in the hospital. So let's look through his orders and talk about why each one of these orders are done. So this EKG monitoring, SpO2 monitoring, why we want to do that? He's in AFib, so he's at high risk to do what? To go super tachycardia. SpO2 monitoring, he can't breathe. Vital signs every hour, PRN, intro. Oxygen per nasal cannula to keep his sat above 92. So it says per nasal cannula, so how high can I go up? I can go up to 6. He's already on 4. Do I have much room? I really don't. So if I have to get to 6, what am I gonna have to do? Yeah, I'm gonna have to call and get my order updated. I hate it when docs write orders like this per nasal cannula because it puts a limitation on it. So if it had not said per nasal cannula, if it just said oxygen to keep sat above 92, then I could go up even higher, get me a face, like the appropriate masks that I need in order to go up higher on my oxygen. But I don't have that right now, so. Activity, bed rest, plan. Yeah, his heart is working overtime. I do not want him up exerting himself anymore. Intake and output, call provider, if your output is less than 100, well, he already failed. So, because he only had 50 per hour, so he had 150 every 3 hours. So we're really wanting him to diurese a lot. That's not happening. Diet, 2 grams sodium, low cholesterol, 1. Yeah, so low sodium because I don't want to hold on to water, low cholesterol because it's just a good heart healthy diet. Do you have a question?
I'm just stretching.
Peripheral IVs times 2, why do I want 2 IVs? Is he stable? No, I want 2 IVs. So when you have unstable people, you want 2 IVs. Especially if you've got to run drips in one, you need another one to do other medicines for. Okay, so medications. I can't say that word. That's Entresto. So this is a ARB. So this is it's something else like ACE inhibitor and an ARB. How is this going to help him? It's going to lower his blood pressure, because what was his blood pressure?
50 number, age of.
Yeah, let's grab his one really quick and see what we're doing right now.
Hi, I'm Amy. I'll be your primary nurse today. I am attaching this blood pressure cuff so we can monitor your.
All right. Which arm do you need?
I want to use your right arm, please.
He sounds awful. What do you think of his heart rhythm? It's so tiny. He needs new pads. It's a terrible artifact. Probably because he's probably diaphoretic and sweaty. 155 over 93. Let's do, y'all, what other assessments y'all want to do real quick? Listen to his, oh no, it's not that, it's oscillator, there we go.
I need to listen to your lung sounds with my stomach.
Okay, what do you want me to do?
Just don't speak while I look.
Be quiet. Just be quiet. What y'all want me to put? He got 80 milligrams of furosemide, and he's gonna get 60 more. So we're gonna watch that potassium level. Echocardiogram was done, chest X-ray was done, 12-lead EKG was done. Radiology. Chest X-ray shows signs of congestion, enlarged heart. That matches with our expectations because we have an enlarged heart. The echocardiogram shows irregularity with AFib, enlarged left ventricle, which is in line with heart failure, and it doesn't tell me a percentage of his PF for this time. Hopefully it is elapsed. So his hematocrit and hemoglobin are low. His hematocrit is 30, the low is 42. So why is his? It could be delusional because he's fluid volume overloaded. So his hematocrit is low. Platelets are good, white blood cells are good. Sodium is 133. Yeah, he's fluid volume overloaded. So his sodium is diluted out. So there's two pieces of lab data that says he's fluid volume overloaded. Potassium is 3.7, so the Lasix hasn't brought that out too bad yet. BUN is elevated, creatinine is elevated. So, yep, we already expected that because he didn't give me a lot of urine output with the Lasix in the first place. His glucose is actually not that bad. It's